Let's focus on osteoporosis today. Now, in osteoporosis, you have a weakening of bone. Remember that bone is supposed to be hard, solid. As we grow older, this bone gets weaker. And the main cause is removal of calcium from bone. That removal of calcium will result in a weakening of bone, or something known as porous bone. This porous bone results in fragile bone, otherwise known as fragile bone disease. So osteoporosis or porous bone, fragile bone disease, they all mean the same thing, which is essentially the bone has become weaker, making it more susceptible to fractures. Typically, the patients that are affected by osteoporosis are women, and more specifically, women of white or Asian descent. Again, pregnancy, breastfeeding, menopause all increase the likelihood of suffering from osteoporosis. Reason being is pregnancy, breastfeeding, or menopause cause a loss of calcium in bone. Now, this loss of calcium in bone will lead to weakening of bone. It will lead to the development of porous bone or osteoporosis. Again, it has to do to losing calcium in the bone. Remember that in the bone you have a constant remodeling. You have calcium being deposited by osteoblasts, and then you have calcium being removed by osteoclasts. Okay, so osteoclasts are going to remove calcium from the bone. Now, if we have an excess amount of osteoclast activity or an excess amount of calcium removal from bones, that will result in a weakening of bone structure or osteoporosis. So let's focus on some causes, risk factors that you need to know for the NCLEX. Number one, 65 years of age or older. Again, osteoporosis typically affects women and those of white or Asian descent. Also, if your patient has a low calcium intake, this makes it less likely for calcium to be deposited into bone, again, causing weak bony structures. Or maybe, for example, the patient is lactose intolerant. They can't tolerate milk products, cheeses, milks, yogurts. Again, that decreased calcium intake is going to make for weak bony structures. Maybe the patient has a problem with alcohol, excessive alcohol use. Again, this can also cause weakness to bone. We just talked about this briefly. If the female patient is postmenopausal, again, this is going to make it so that there is increased amounts of calcium loss. The patient is on corticosteroid therapy. Are they on any prednisone? Is the patient maybe a patient that suffers from rheumatoid arthritis and they have been put on the corticosteroids? If so, again, you must know that the corticosteroid use may cause osteoporosis. Also, is the patient on any thyroid replacement drugs? Did the patient have any thyroid surgery? Again, this predisposes them to suffer from osteoporosis. Is the patient on any heparin use? Are they taking any Dilantin? Also, is a patient suffering from any inflammatory bowel disease? Again, if you have problems with your digestive tract, that is also going to impair the amount of calcium absorption through the GI tract. So again, if you have problems with your GI tract, you're going to have impaired calcium absorption, which again will lead to decreased amounts of calcium in the body, which will result in weakened bony structures. Also, is a patient having any type of kidney disease, any chronic renal failure, any acute kidney injury? Because again, this will also affect the amount of calcium that is retained in the body. So let's focus on some clinical manifestations now that you need to know for the NCLEX exam. Now, at the beginning of the video, I had a picture of a patient with kyphosis. Now, typically, patients that suffer from osteoporosis, you must know that the spine is affected, the hips are affected, and also the wrists. These are the three locations that are typically affected with osteoporosis. So with the spine, remember that in a standing position, your entire weight rests on your spine. And a lot of that weight rests in two main locations, in your thoracic region, or in your T-spine, and also in your lumbar spine, your lower spine. So if you have that large amount of weight on your thoracic spine, and if you have a weakening of bony structures or weakening of the vertebra, what can actually happen is the spine will collapse onto each other. If this happens in the T-spine, what will result is something known as kyphosis. So you have that bending of the thoracic spine. Now, there are a couple of problems with kyphosis. A couple of the clinical manifestations that you will see on your patient may be something like back pain, loss of height, or curvature of the T-spine. Now, my grandmother, perfect example, she lived up to be 92 years old. And one of the problems that we saw as she got older is that she became shorter and shorter. Because again, her T-spine continued to collapse onto each other. So again, she got shorter and shorter, or she had a loss of height. Now, because your spine is compressing onto each other, it's breaking. Again, patients will typically complain of some back pain. Now, the other problem with kyphosis is that if you take a look at the images that I posted at the very beginning of the video, you'll find that again, there's a curvature of the spine. Now, because there is a curvature of the spine, especially in the thoracic region, that's going to make it very, very difficult for that patient to take deep breaths in, because you're losing some of that space for lung expansion. So as the patient gets older, patients that suffer from large amounts of kyphosis or a large curvature of that T-spine, one of the complications that these patients run into are like pneumonias, because again, they can't take those deep breaths in. So that's another lecture, but make sure that you're aware of that. This is, again, a result of kyphosis. Again, the patient isn't able to take deep breaths in, makes it more likely for those patients to suffer from atelectasis and pneumonias. Number two, now I, for example, work on the surgical floor. So most of my patients that come in have had some type of fall. Maybe they got up to go to the bathroom late at night, they slipped on a rug, and boom, they fell down and fractured their hip. So this is the majority of the patients that you will see on the surgical floor. If the patient has something like a kyphoplasty done, we'll get into that here in a little bit with our therapies and treatments. Again, most of the patients you'll see on the floor are patients with hip fractures. Most of the times, you will actually see a shortening of the affected hip or the affected extremity. And also, sometimes there will be multiple fractures. They will fall and they'll try to catch themselves and end up with a wrist fracture. Now, what are some diagnostic studies that you need to know for the NCLEX exam? The number one thing that you must remember for the NCLEX exam, as far as diagnostic studies go, is the DEXA scan. Now, you can do x-rays and you can even do lab work. But typically, if you look at serum calcium, serum phosphorus, or the alkaline phosphate levels, you will actually notice that these levels are normal. They're not going to be elevated. I equate osteoporosis kind of like, I equate it to hair loss. You're not going to go one day full head of hair, next day completely bald. It's not going to happen that way. And osteoporosis, again, one day you're not going to have full strength of your bones, and then the next day you're going to wake up and all of a sudden you're going to have porous bones. It doesn't happen that way. It happens over a long period of time. And because of that, typically these calcium levels, phosphorus levels, alkaline phosphate levels are not going to be elevated if you were to do lab work. So you cannot rely on these lab values to indicate that there's osteoporosis going on. The number one thing that, again, you need to know is the DEXA scan. And in the DEXA scan, the thing that you need to know is the T-score. The T-score is just measuring normal bone density. in a normal adult or a normal T-score is a -1. Is a level of greater or equal to -1. In osteoporosis, however, the T-score is going to be less than -2. Again, this indicates that there is little or no bone density. Unfortunately, for osteoporosis, you don't really know that osteoporosis exists until either the patient falls down, they suffer some type of fracture, for example, a vertebral fracture, or family members notice that there's something like kyphosis going on. Because if you were to do a X-ray, X-ray is really not going to show much. You can do X-rays of the spine and long bones, but until there is severe bone loss or severe bone weakening, you're not going to notice that there's osteoporosis present. Therefore, the best thing that can be done for the patient is a DEXA scan. And again, unfortunately, the DEXA scan only serves to show that, yes, there is osteoporosis present. It doesn't really help prevent it. Another thing that can be done is something known as the quantitative ultrasound. If you see that on the NCLEX exam, you must know that an ultrasound of the heel is what is actually being looked at. Okay. Again, the heel is what is actually being examined under the ultrasound or the quantitative ultrasound. But again, you must know that the number one thing that can be done as far as diagnosis goes for osteoporosis is the DEXA scan. And again, you're looking at the T-score. I've never really seen any questions regarding the T-score, but I'm just throwing it out there in case you see it, you know that it's referring to a DEXA scan. So let's move on to some therapy and interventions. Number one thing that will most likely be done is the patient will be put on some kind of calcium supplement. Now, depending on the physician's orders, it may range from 1,000 milligrams per day to 15 milligrams per day. Again, this will be determined by whether the patient is pre- or postmenopausal. Calcium supplements may include something like Oscal, Caltrate, or Citracal. Now make sure you go back and study your pharmacology, because depending on which medication is given, you may need to give it with meals, post meals, or before meals. So make sure you go back and check out your pharm. Also, you may tell your patient to increase their intake of foods that contain calcium. So you have to know a couple of these for the NCLEX exam. So these include things like whole milk, skim milk, yogurt, spinach, cheese, or ice cream. Now, there is a problem if the patient is lactose intolerant. So if the patient is lactose intolerant, they're obviously not going to tolerate any of the milk products, in which case you would revert back to the calcium supplements. Also, a thing that you must remember for the NCLEX exam is that these calcium supplements, or you consuming large amounts of calcium in your diet, does predispose you to the development of renal calculi, renal stones. So you must be aware of that. You must also be aware that if you are providing these calcium supplements, you must monitor serum calcium levels. And if you are going to be giving these calcium supplements, make sure that you understand that they may also cause a GI upset. So that was number one, calcium supplements. Number two, vitamin D supplements. Again, this is given in combination with the calcium. Again, this is very important for postmenopausal women or patients in a nursing home setting. Because again, remember that the way you get your vitamin D is by going out, spending about 20 to 30 minutes in the sun. So make sure you know that for the NCLEX exam, spend about 20 to 30 minutes out in the sun and you get your vitamin D for the day. If, however, this patient is a nursing home patient, most likely they're not going to be out and about. They're going to be kept inside a nursing home. If that's the case, they are not getting the vitamin D. They're not getting the sunlight exposure that they need. So you will have to supplement this vitamin D. The same thing with calcium intake. You're going to have vitamin D being increased in their diet along with calcium. So please make sure you monitor for kidney stones. Are they having any flank pain? Are they having any hematuria? Number 3, exercise. Now, I have seen this question plenty of time on practice exams. Now, as far as exercise goes, you want to make sure that the exercise is some type of weight-bearing exercise. Whether it's walking, weight training, again, lifting weights, stairs, climbing stairs, any type of hiking. Again, you want to try to make that bone strong. If you see something like swimming, that's a no-no. That puts no weight on the body. Again, we want to put weight on the body to hopefully make that bone strong. However, you will not do running. Okay, let's take it back. We talked about how osteoporosis is going to be a weakening of bone. Typically, osteoporosis is not diagnosed until, again, you have severe bone loss. So right here, if you were to put these patients on running, you have all that weight on those knees, all that weight on those ankles, and on the spine. So anything with jumping up and down is going to make it very, very likely for those patients to suffer from some type of fracture. So running, you must tell the patient to try and avoid running. Okay. The way that weight training works is, again, you're using muscles to pick up those weights. Muscles will actually begin to pull on bone, making that bone strong. So that is why we want to focus, again, on weight-bearing exercises. Most important of all, you want to educate your patient to remain active. Inactivity will only promote further bone weakening. So again, you must inform your patient to remain active at all times. Now, I briefly mentioned this earlier when we were talking about kyphosis, or that curvature in the T-spine. Treatments for that could be something like vertebroplasty or kyphoplasty. Now, typically, if a kyphoplasty is done, patients will be sent to the OR. A small balloon with cement will be put into the T-spine, hopefully getting rid of that collapsed T-spine that's in place, hopefully relieving some of that pressure, relieving some of that pain. After surgery, patient will be sent up to the floor, just observed overnight. And typically for kyphoplasty, things like Percocet may be given for pain control. In the morning, patient is discharged. So it's not a real big surgery by any means, okay? Number 5, now we're getting into some of the drugs that may be given for osteoporosis. Something like calcitonin or calcimar. Now again, calcitonin, we talked about how osteoblasts help deposit calcium into the bone, and osteoclasts remove calcium from the bone, causing bone weakening. So calcitonin, what it does is it inhibits osteoclast activity. Therefore, calcium isn't removed from bone. Now, calcimar can be either given in a intramuscular, subcutaneous, or intranasal way. If you give it intranasally, you must inform your patient to alternate nostrils daily, because this medication may cause nasal dryness and irritation. So again, make sure you tell your patients to alternate nostrils daily. If you're going to give this IM or sub-Q, you must inform your patient that it may cause some nausea or facial flushing. So taking this medication at night may help resolve some of these symptoms. So that could be a patient teaching that you can do. Again, educating your patient to take these medications at night. The Calciumar IM or sub-Q, again, take it at night. Now again, with the calcitonin or the Calciumar, patients must still take calcium supplements. And as always, we want to monitor our calcium levels. Yes, we want to make sure that we're putting more calcium into the body, but again, we want to make sure that we do not put too much, will cause hypercalcemia. Also, again, we have to be concerned with kidney stones. Number 6, the biphosphonates, Fosamax, Iridia, Actonel, Boniphos, or Boniva, excuse me. Now, with the biphosphonates, these may cause weight loss, or gastritis, or esophageal irritation. So you must know that for the NCLEX exam. Also, for the NCLEX exam, you must know to tell your patient, to educate your patient, to take the biphosphonates, again, either the Fosamax, Iridia, Actonel, Boniphos, or Boniva. You must tell these patients to take these medications with a full glass of water. Also, take it 30 minutes before food or other meals. Take it 30 minutes before food or other medications. So if this is a patient on the floor, you want to make sure that these medications are given before they have their breakfast. And again, you're going to give them a full glass of water. And the most important thing of all is that these patients must remain in an upright position for at least 30 minutes. Again, you want to prevent esophageal irritation. You want to prevent gastritis. You can also give something like Reclast. Now, Reclast is a once-a-year IV infusion. I believe this lasts up to 2 years. Or number 8, you give something like Evista. Now, Evista mimics the effects of estrogen. Now, I'm not really going to focus on the estrogen replacement drugs because you can run into some other complications, but Evista mimics the effects of estrogen. So this is typically given to postmenopausal women. Now, the thing about Evista is that it may cause leg cramps and hot flashes. It also predisposes patients for the development of blood clots.